Internet-based tele-surveillance and tele-rehabilitation are integrated approach in a Parkinson disease population, telepark. Presenting is Dr. Balsamo.
I work in a neurorehabilitation department in Maugeri Institute of Veruno, directed by Dr. Maggioni. And now I want to speak about tele-rehabilitation in Parkinson's disease. We know that Parkinson's disease has a profound impact on daily performance and quality of life. Lifelong rehabilitation measures and medication are the gold standard for treatment. Nevertheless, poor adherence to rehabilitation and difficult access to rehab facility setting are real barrier. Telemedicine is a valuable means of care delivery, but existing studies are lacking with little poor evidence. We depict an integrating telemedicine, tele-rehabilitation randomized trial to enhance home program. Now I want to show our experience in Veruno Institute in this study. We have to evaluate feasibility of a specific program of telesurveillance and telerehabilitation in Parkinson's disease patients based on the design of our experience in telerehabilitation in neurological disease. And the medical coordinator center is Maugeri Institute of Veruno. Inclusion criteria: age 18, 80 years old, on a year scoring between 1.5 and 3, stabilized drug treatment with L-DOPA or dopamine agonist, and access to internet. Exclusion criteria are inability to participate in exercise programs, other neurological, musculoskeletal, and cardiopulmonary pathologies that compromise movements and obviously not science consent, cognitive impairment using a screening test as a mini-mental state examination and cognition Montreal assessment. Patients were randomly assigned a control group or telemonitored group patient. Both groups were asked to carry on custom-tailored exercises, 20 minutes, 30 minutes for day, 2 days weeks for 3 months. In telemonitored group patients are provided with instrumentation, tablet PC with video conferences capability for support during scheduled contacts. The assessment. Neurologists, physiotherapists, and psychologists assess patients at the baseline and after 3 months. Baseline time of enrollment. Indicators used are 6 minutes walking test, mini best test, time up and go test dual task, board scale, new freezing of gait questionnaires, UPDRS second, third part motor score, anxiety depression scale, and quality of life in Parkinson's disease. This is a framework that represents a pre-phase in which patient can be evaluated in a phase of pre-discharge, give a possibility to enrollment. And this is a time also for education and training session to use the device and instrumentation provided to the patient, and a phase of operational phase in which the framework, the coordinator framework, is a service center who gave the possibility to contact the patient and caregiver, and first of all to contact nurse tutor, expertise nurse tutor or physiotherapist to put in contact patient and caregiver for giving the possibility to follow patient with motivation questions and gave patient also a sort of follow strictly and the correct program, rehabilitation program in the 3 months of observation and treatment. And service center is the main coordinator that can schedule program, schedule calls, and offers nurse and physiotherapist the possibility to monitoring patient, also with unscheduled calls. All calls and contacts are recorded. On monitoring, telemonitoring the disease, the case, the devices, and all the instrumentation that consent and allowed to follow patient at home. And in our study, this population is divided into groups, control and telemonitoring groups. No differences in terms of number, 19 and 19 patients. In the telemonitored group, there is slightly difference in terms of age and length of disease. There is a shorter length of disease of Parkinson's disease. On a year point score is light low in the telemonitored group. All patients complete the protocols. In the mini-best test, considering mini-best test and 6 minutes walking test, there are no differences in the 2 groups, but in time up and go test and time up and go test dual task, there is a difference in a control group in terms of timing to perform this test, and the control group go worst. And in regarding UPDRS third score, motoring score, there is improvement in terms of decrease percentage at the total in the telemonitored group. False and near false. About near false, there is a decreased number of false in after treatment after 3 months in telemonitored group. Considering quality of life in Parkinson's disease, in the 8 sub-score test scores in 8 domains, we can see that in control group, cognition domains are interesting, is involved, and show a worse if consider telemonitored group. Mobility, ADL, emotional well-being, stigma, and bodily discomfort in telemonitored group has had a positive trend after 3 months. If we consider a second evaluation after 3 months at the first evaluation, we can see that there is after 6 months at the baseline and a positive effect in terms of the improvement in telemonitored groups. Telemonitored group patients were slightly younger, with a shorter length of disease and poorer on a year scoring that improved after telemonitored treatment. A main improvement was detected in motor aspects in terms of a reduction of falls, reduction of timing in time up and go test and time up and go dual task, and functional aspect and bodily discomfort in quality of life in Parkinson's disease in sub-score tests. The evaluation of data in telemonitored patient suggests as a feasibility PET evidence of a few technical problems with the resolution by an expert team. In addition to home access, good results in terms of adherence to and tele-rehabilitation with surveillance. And considering the 2/3 size of the sample that is evaluated at 6 months, it seems there is a positive effect in terms of complete inclusion and compliance to the protocol. This effect in control group is lower if compared to the telemonitored group that show a regularly decreasing trend over the 6 months. Our study shows motor improvement and maintenance in of monitored patients with Parkinson's disease following a tele-rehabilitation program. This improvement confirmed at the 6 months it's possible due to increased compliance with the rehabilitation treatment, increased punctuality in implementation of rehabilitation treatment, and increased the motivation to carry out rehabilitation treatment. And these 3 points can be made the main components of a tele-rehabilitation. So to conclude, tele-surveillance may reduce barriers, enhancing home rehabilitation by improving outcome and accessibility, potentially increase frequency and intensity of administration of rehabilitation therapy, and it's desirable to ensure continuity of care over the time after discharge, but and in the space, not only in the time, in the space in terms of from hospital to the patient home. And these results are only still preliminary, but this observation on improving results and reducing obstacles are encouraging. Thank you.
Okay. Thank you for your very clear presentation. We have a couple of minutes for question. Meantime, I have a question for you. Did you analyze or did you consider the role of the caregivers in the improvement of compliance of the patients? We know how important is the caregiver for patients, for Parkinson's disease patients. So did you have any comments on this?
Yes. It was considered patient and caregiver, and all scheduled contacts took place with the presence of caregivers, and each controls, or also specialist control, neurological controls visit was supported by a caregiver, and it's will be to have questionnaires also for caregiver and satisfaction questionnaire for caregiver